Afternoon, everybody. I hope you all enjoyed our music selection this afternoon. Welcome to the Health Equity Jam session for April 2026. We're really excited to have you all here today and hope everybody's doing well. I know there's a lot going on around the world, and so we're just all grateful to be here and to be healthy and to have all the support we do have. So just wanted to say that. And I think I did say if you are new to the jam session, please type your name and organization and or your location in the chat so that we can become familiar with you. And after that, I'm just going to say, for those of you who don't know me, if you are new to the jam session, I'm Dr. Lisa Cooper, and I'm the director of the Johns Hopkins Center for Health Equity. And it gives me great pleasure today to introduce our speaker for today. And we're going to start out as we usually do with our fun facts about our speaker. And we try to get some audience participation in here. So we may have you guys participate and take a guess at some of these fun facts. So first of all, I hope you all enjoyed the music. I love reggae, so I was totally into that. But and that wasn't necessarily a clue for anything. I'm just letting you guys know in case you're thinking that the music is a clue. So anyway, so the first fun fact about our speaker is related to her I don't know. She likes line dancing. Let's put it that way. So how many people want to guess what her favorite line dance is? I don't know that many of them, so but if you know a lot of them, maybe you'll be able to guess which one it is. So, we have Cupid Shuffle. We have Electric Slide. What else do we have here? We have 2 Cupid Shuffles and 2 Electric Slides, so it's a tie. Anybody want to break the tie? Oh, Cha-Cha Slide, which I like. I do actually know those. Let's see, but oh, wait. Okay, Boots on the Ground. Okay, I don't even know if I know that one. I might know that one. Okay, okay. Well, we already got it. So Dr. Felix, do you want to tell us a little bit about your favorite line dance and why you like it?
Yay! Hi everyone. It's the electric slide. I love the electric slide. I have to tell you, if I was talking to the president and the electric slide came on, I'd be like, 1 minute, I'll be back. Just hang in with me. I'll be back because I just have to. It's like it's my favorite dance of all times. Woohoo! Nice. I see I get some love. Like people are like, yeah. So we have some fans of the electric slide as well. Good.
Yeah. Do you like some of the other ones too? Do you learn
Oh
all of
yeah. I mean, I love boots on the ground. I've not been able to. It's complicated.
them?
I've come close to dancing, to getting it all, but not enough practice. I know
Uh,
all the others. And I join in. Whether I can do it perfectly or not, it doesn't matter.
yeah, I know what you mean. Sometimes, even if I know the dance, if I'm like the first person out there, it's like, oh, all of a sudden I can't remember what I'm supposed to do because everybody's like looking at you and
I
waiting for you
know.
first move, right?
I know. I join, but I just go to the back.
Right. Right. No, that's smart. So, okay, well, let's go to our second fun fact is about a hobby of Dr. Felix. That in addition to dancing the electric slide, there are some other things that she likes to do. So, what does she do in her free time? Gardening. Okay. Knitting.
Hmm.
Pickleball. We've got some good guesses here. painting, photography, yoga. Nobody's close yet. Other styles of dancing, playing an instrument, singing. Okay, good guesses, guys, but nobody has it yet. Traveling, running, getting a little bit closer, I think. Um, Dr. Cruz. We've got camping, strength training. We've got some that are so be okay. It's a combination of walking, running, and camping. Oh, bing, 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 bing. Dr. Nurali got it. Hiking. Okay.
Yay! All
So tell
right,
us,
Ali. Outstanding.
yeah, tell us about your hikes.
Oh
Where,
man,
where?
I love nature. I mean, I don't know if you guys have that experience, but I go into nature and I can feel the stress leave my body. I can physically feel it. So I just hike. I live in Trenton, which means that I do the two bridge. We have the two bridges. So Trenton is on the is on the Delaware River, and right next door is Pennsylvania. So every morning I'm up and about and I do 2 mile to 3 miles, and that's easy. And I like to go into I mean, I'm just down for a hike wherever it is. City hike, mountains. I mean, I just love walking, and I think it's really, personally, I don't think there's any problem walking cannot solve.
I'm with you on that one. That's one of my favorite activities too, because it combines healthy activity with healthy physical activity with a connection with nature, and
Yeah.
it's just so healing.
It
So
is absolutely. And can I say something? It may be bordering on the TMI, but it's a plug for walking. There are
mhm,
some conversations me and my husband cannot have sitting down, but we can
mhm.
have them when we're walking.
No, I can too. I can
I see
imagine why.
smiles, I see nods. You know what it's like.
So
Oh
that's a good tip,
gosh.
guys, for those of you who haven't tried that before. I think that's like an excellent idea. I love that. I love that. So we've got one more fun fact. And, we always like the Health Equity Jam session loves food. So everybody here loves food. So we're going to take a guess at Dr. Felix's favorite cuisine now. I love this one too. Oh, we have two people saying Thai cuisine and Indian. Malaysian, Mexican. We're not there yet. We've gone to two different parts of the world. We've gone to another. We're in the Caribbean. That's a good guess too. I think we're getting warmer. Somebody just put has the right continent down there. Oh yeah, Persian. Yeah, Persian food is great. Mediterranean,
Yeah.
Italian, Greek. Well, the person who's we're getting really close. Kenyan, Nigerian. We're almost there. And aha, we got it. We got Dr. Nurali and Claire Liu as well. So well, I wish it was Liberian, but yeah, so Ethiopian cuisine. So tell us more about that. I love it.
Yeah, I love Ethiopian cuisine. I discovered it. I lived in DC, in the DC area for almost 20 years, and I just fell in love with Ethiopian cuisine. Of course, all the varieties, but the fact that you use your hands to eat it, I think like that's what I love, and I love eating with my hands. Yeah, and I think there's something about eating with your hands. I really think it's a different experience. And so I just love it. I love injera and all the different sauces and all the different beans and vegetables. It's fantastic.
I love it too. I love it. And what I like about it too is that it's communal,
It
because
is.
everyone sort of sits in a circle and there's
Oh my
this big
gosh.
platter right in the middle. And yeah, it just feels
Yeah.
very much like a sense of community. And
Absolutely. But I could also add like West African food because I was in Ghana a
Mhm,
couple years ago. It was in 2018. And I went to a
mhm.
restaurant where they brought me the food and the fufu, and they brought me a basin to wash my hands. I was just like, oh my God. It was such a nice experience. So I love West African food. It was a tie between Ethiopian and West African food.
Good answer. Good answer. West African food is always a good answer in the jam session. For many reasons, but including that yours truly is of West African uh, origins. So, but okay. So, well, we will move on to the formal part of our introduction, and then turn the floor over to Kaytura. So, Dr. Kaytura Felix is she calls herself a spiritual activist in pursuit of health justice. She brings together medicine, health services, community-based participatory research, and generative leadership coaching. She's a distinguished scholar at the Johns Hopkins Bloomberg School of Public Health, and there she founded the Black Birthing Futures Project, which studies the experiences and impacts of Black community midwives on Black communities across the US. As a physician, lead researcher, and host of the Deep Care podcast, Kaytura uses narrative nonfiction storytelling to bring these findings to life and to advance systems change in Black maternal health. And here it says, in her free time, she spends time with her sister circle and takes long walks with her family in Trenton, New Jersey, where she lives. So without further ado, over to Dr. Kaytura Felix.
All right. So this is wonderful. I'm really happy to be here with you guys. Thank you very much. Thank you for playing with us. I don't know what you think about that, but I would invite you guys, if you can turn on your cameras, to turn it on. It's a very different experience, and it's a request that I make. You can accept it or not, but I would love it. It would make me very, very happy. So let me start by sharing my screen. Okay. All right, I'm going to share the sound. Okay, let's see. 1 minute. Something happened to my computer. Okay. Over here.
We did a dry run of this before, just to let
I
you
know. It's fine. And I'm just going in. I want to give you guys a good experience. Okay. This. So let's see. Let's see where it takes us. Okay. Okay, guys, can you see my screen? All of it?
Yes.
All right, perfect. So good afternoon, everyone. I was telling, Dr. Cooper and colleagues here that I'm so excited to be with you this afternoon. I've been on the other side of the Health Equity Jam many a times, with my screen on and off. And so I'm really happy to be here. And I feel like it's an honor and a pleasure to be with you guys. So I'm going to take you on a journey, and I'm really excited about this journey. During this journey, I'm going to share our asset-based approach to research on the Black maternal health. I'm going to share the findings and recommendations from our multi-phase study. I'm also going to describe the research process, including the study design, results, and the proposed impact that we want to have. And I also want to spend some time unpacking and describing our upcoming dissemination strategies. So, before we start our journey, I want to do what I call a wisdom check. And I just made up this word, right? I'm assuming that there is wisdom in the room. Yes, I'm here speaking, but there is more wisdom in our Zoom room than I can imagine. And that there are people here who know about Black maternal health, care about Black maternal health as much as I do, or maybe even more than I do. And so the question I want to pose with you is, what's the Black community doing to address the crisis? We've heard about the crisis, but drop in the chat what you think the Black community is doing about the crisis. And don't overthink it. I'll give us about a minute or so. So just drop it in the chat and I'll take a look. So if somebody would want to just read what comes up in the chat, if anything, I'd love that. It can be nothing, it can be a lot, it can be I don't know. All right, so I didn't see anything. And did anybody write anything here? So we're going to move on. We are going to move on.
You
So,
haven't seen anything? There have been several things
oh,
in the
there have
chat.
been?
Yeah, do you want me to read out what
Please.
some of
Yeah, it's
them
not
are?
showing up on my end.
Okay, so one of them is promoting doulas and
Yep.
midwifery.
Uh-huh.
There's uh, increasing home births versus hospital, forming advocacy organizations, educating one another and providing resources, raising awareness, increased community approaches, sharing research, spreading the word, and advising Black women to be vigilant about their maternal health, birthing centers in the community, identifying challenges and status quo, community engagement and education, and using media to share stories.
Perfect. Oh my God. You see, I was right. There was a lot of wisdom in this room. Happy that I made this wisdom check. Fantastic. So, the question that I just shared was the question that I had in 2023 when I started this research. But we're not going to start our journey today in 2023. We're actually going to start our a little bit different. I think we're going to do today is maybe a little different for a research center talk. I'm going to begin our conversation in the present slash future. And then we're going to go back to 2023. Put it another way, I'm going to be starting our conversation by sharing with you what we're doing in our dissemination of the research. So where we are today with the dissemination, and then we're going to head back to 2023 to look at the research, to look at the findings, and to come back to where we are today. So I'm really excited about that. To do that, to share with you our dissemination strategies, I'm going to share with you a 10-minute clip of what we're doing to disseminate our findings. So here we go. I'm Kaytura Felix, and you're listening to Deep Care, a podcast about the Black community midwives transforming Black families and futures. I heard from so many Black parents with beautiful birth stories while doing this research. Like Shayla in Florida.
My husband was like, well, the water is not ready. And I said, well, it's ready enough for me. And I jumped in on one knee. I jumped in the water and I was pushing. And Kim came right in the door just in time. She threw everything down. She put on her gloves. I pushed and baby boy was out. I was on one knee like Kaepernick.
And like AJ in Hawaii, who had her baby in the hospital with her community midwife there to advocate for her.
She actually videoed the birth, and you could see her coaching me through, even when I felt like a lot of the staff were trying to rush me to, get the baby out. They're telling me to push, hurry up, get it over with. And she's like, no, don't push. Wait. Your body is going to naturally contract and you are going to know when to push. And it took a little while. I just sat there, just kind of breathing with the baby's head right there, and she's just, it's okay. Remain calm. I felt it, did the final push, and baby came out. And I accomplished all my goals, my natural birth goals, which I know would not have happened if she wasn't there.
Many of the parents we spoke to who'd given birth in hospitals without midwives present had something in common. They'd experienced a particular kind of stress related to birthing while Black. They'd heard about the maternal mortality statistics or faced the neglect and mistreatment that so many Black people do in the healthcare system. So they expected for their births to become medical emergencies, for their bodies to fail them. Midwife Kim Onele reframes this idea.
I push back against the idea that Black bodies are inherently high risk. That's not true at all. That's not true. It's the social external pressures around us that are misaligned.
Kim Onele is the third midwife in our series. Yes, another midwife named Kimberly, and she's impressive. All the midwives I met were incredible. Still, Kim stands out. She's trained as a lawyer, but really, she reminds me of a scientist, a data nerd. She makes her points, and she has the numbers to back them up.
There's been an uptick in employment discrimination against pregnant women. I did a deep dive into fetal growth, into fetal measurement, into ultrasound. When I've looked at the regulations from state to state, they generally list the same exclusion. But I read the reports. I was reading medical journals. I looked at World Health Organization statistics and growth charts, and so that's why I keep the data. I'm not trying to prove a point. I just want to see if what I'm doing is resulting in positive outcomes.
While Kim was in law school, she had her third pregnancy. It was the first time she was cared for by community doulas. That changed everything. That's where she saw the power of women caring for other women. After graduating, Kim switched things up. She left law to become a midwife.
So the law is an institution that takes a long time to make change. And midwifery is an experience that can actually impact multiple generations within the span of one pregnancy. So it's a lot of impact in a short period of time. And that's just more in line with the way that I move through life.
I first met Kim in a strip mall on the outskirts of Kansas City. She invited me inside a co-working space that looked like an essential oil store. We shared a leather couch so we could talk. While Kim is serious, it's the kind of serious that puts you at ease. I was so comfortable that I forgot to take out my recorder. Then I forgot to turn it on. This is the first time that has happened. Okay.
Yeah. So Kansas is unregulated.
Once it was up and running, Kim and I dove into discussing her practice. The majority of Kim's clients are Black. Over the years, she's tailored her midwifery care to their experiences, particularly the experiences of stress. There are many reasons pregnancy can be stressful. On its own, it's taxing on the body and mind.
Pregnant women are like running a marathon sitting still. Like their bodies are metabolizing and burning energy and consuming all of the reserves, right, just to maintain the pregnancy.
And pregnant people are also dealing with the demands of work, family, finances, and relationships. Whew. Life is made even more stressful for Black people. We have to contend with the stress of racism. When we walk into a prenatal appointment, there's the additional strain of knowing the scary maternal health statistics, of worrying your provider may not have your back, of having to advocate for yourself when they don't. Kim helped me see how this stress can lead to worse outcomes for Black birthing people.
A lot of these moms are scared. They've been trained to believe birth is traumatic by the statistics that are promoted in society, that Black women are more likely to die during childbirth. They walk into that OB room terrified. Their body is responding to the environment in panic. And when our bodies are stressed, we're going into adrenaline cortisol overload, right? And our body perceives that environment as a war zone.
Yeah.
So our body is running a marathon while fighting a war.
They're feeling that stress for a valid reason. Kim's clients often tell her that before midwifery care, they never felt like their medical providers listened to them, that no one cared enough to pay close attention.
And if the provider is not seeing them and attuned to them, how are they going to catch things? How are they going to prevent things?
I love that word, attuned. It suggests something more than the routine checkups or checking off boxes. Having a provider attuned to clients requires deep listening and humility, because clients know their bodies and their lives are anything but simple.
That is where the malfunction is. It's not the woman's body. It's the external experience around her. Because when our bodies are left alone and our bodies are supported, physically, mentally, emotionally, spiritually, and all of that, our bodies work very well. They work very, very, very well. And I see that all the time.
So that's the kind of support that Kim works to provide. Support that helps our bodies work as they're designed to. So finding Kim was a dream come true for WD.
She literally pertained everything to me and my personality. So, of course, I'm a first-time mom. I had a million questions.
WD says in their early meetings, Kim would sometimes give her the last appointment of the day, just so they could have extra time to talk. And man, would Kim listen.
I'm talking about, I never seen her look at her watch or her phone. I know you don't feel that a lot by like your provider, but literally I felt loved by her.
It's true. Kim has lots of love for her clients, but she also has her own young children at home to support. As she developed her practice, she had to figure out how to balance both.
I started out having a completely bleeding heart and just wanting to help everybody. Like, I was willing to self-sacrifice so that they could have what they needed. And there was one month where I had 6 births, which is a very busy month for me, and I did not have money to pay rent. And I said, how did I get here?
Kim figured out she needed to charge a flat fee. $5,000 covers prenatal, labor, delivery, postpartum care, and a birth kit. For the families doing water birth, she throws in a complimentary birth pool. The fee doesn't cover labs, ultrasounds, or physician's visits if needed. But Kim has found ways to make her care affordable.
She's so dope to the point where she literally would just break it out into like payment systems.
As we know, community midwifery isn't often covered by insurance, so most of the families have to pay out of pocket. But like all the other Black midwives we spoke to, Kim has a payment plan. If a client can't pay in full, they can pay it off monthly. At the end of the day, profit isn't the reason Kim does this work. She does it for the love of Black families.
All right. Okay. So if you're like me, we've heard the statistics, right? We've heard the statistics that Black women in the US are 3 times more likely, that Black communities have 70 times higher rate of severe maternal mortality, and that 84% of these pregnancy-related deaths are preventable. But when I started this research in 2023, I didn't hear a lot of attention focused on the solutions. And so I set out my research to really address what I thought was a gap, right? So we know of the alarming statistics, and our research sought to highlight the strengths and the leadership within the community that foster meaningful change. Because I knew that it had to be more than that, that there had to be solutions that the community was already addressing, right? And in the chat, Lisa read all the solutions that Black communities are already doing. So the research question that I shared with you, I started with just that question. What I'm going to share with you are two phases of my research. Phase one, which I will share with you, which was a formative research, where I talked to about 70 experts in the field, and phase two, where I designed an in-depth study to look at community midwives. And what I'll share with you, just the big takeaway from both these research is that community midwives are propelling community-led solutions, and they're actually delivering transformative, high-quality care to birthing people, their families, and their communities. So let's talk a little bit about phase one. As I said, this is the title of a paper, which is Black Community Midwives Perspectives on Black Maternal Health Crisis, a Qualitative Analysis. And that was published in the Journal of Midwifery and Women's Health. It came out earlier this month. What we did, we conducted the study from January to October of 2023, and we conducted structured and unstructured conversations with 57 experts, leaders, artists, practitioners who were deeply knowledgeable about community approaches around maternal health. And we also conducted direct observation of a midwife providing postpartum care. And we conducted that study between January and October of 2023. So I am going to summarize the findings, the themes that came out of these 73 conversations. One, there was a really strong critique about the fear discourse that was happening nationally, right? Many community leaders felt that there was an overemphasis on the dire pregnancy-related statistics without concomitant attention to the solutions. And I use the word concomitant, right? Those two things coming together. And people thought, right, the research participants thought that actually the pregnancy fear discourse is actually in and of itself harmful, because it creates a real toxic fear of childbirth within the community, and fear itself and anxiety is harmful, and the literature bears that out. They talked about a number of solutions, but the solution, in terms of a solution that rose up among the 70 people I talked to, doulas came up, birth centers, but the big theme was around midwifery care and how transformative it is. And they talked about midwives and doulas, doulas being really important, and midwives, because midwives are providers of birthing care, the possibility for transformation, the possibility for innovating outside the conventional medical system. So the Black community midwives, they said, was a solution to the Black maternal health crisis, right? They identified community-based birth as an important yet under-resourced strategy for the maternal health crisis. And I use community-based birth instead of outside of the hospital because it's a different mindset. The other theme that came up was there's a lot of leadership in the community, that Black women are the primary leaders addressing the maternal health crisis. But there was also a critique of that, in the sense that these women are doing this work, they're being lionized, but they are being under-supported, right? So despite the effectiveness of community midwifery and other community solutions, there is inadequate systemic investment and support. So, maybe I don't need the slide. People here know what a midwife is, but a midwife is a healthcare professional who is trained to provide comprehensive care for obstetric, gynecological, and reproductive health. They are experts in low-risk, uncomplicated pregnancies, and they operate in homes, birth centers, and hospitals. And there are many different certifications that people enter midwifery through many different types of certifications. And there's evidence. This evidence is both national evidence as well as global evidence about the power of midwifery-led care, improving perinatal outcomes. And what I mean by perinatal outcomes is the outcomes that deal with both the mother and the baby. All right, so here we were, phase one, people are saying that midwives, community midwives, a solution to the Black maternal health crisis. I knew almost nothing about community midwives and community midwives, in spite of the fact that they were relatives of mine who were community midwives. My aunt was a community midwife, my sister-in-law was a community midwife, and here I was, a physician, completely ignorant about what community midwifery is. So we designed a study, a multiple case study, to really understand why were people saying that that was a solution to the Black maternal health crisis. All right. So our aims were to describe the experience of these birth workers, to describe their impact on families and communities, to describe the conditions that facilitate or hinder their practice. So we had three aims. So in terms of the design of the study, we had an advisory group of 5 Black maternal health experts, including we had an anthropologist, we had an artist who works in this space, we had an OBGYN, a midwife, and a public health person. Our research was very much grounded in Black feminist knowledge and theory. And so we designed a study which was very much participant-led. We traveled to 5 different cities in the United States, in the South, in the Northeast, the Midwest, West, and the Pacific West. The total population of people we interviewed 5 community midwives. So these were the participants. We interviewed 16 midwives clients, 6 family members. I mean, I'll tell you a little bit more about the design. 12 collaborating providers, 14 community stakeholders, and 4 members of midwives' families. Let's see. This is in the wrong place. Anyway, so here we are. I may have to go back. So in terms of our methodology, we conducted in-depth interviews with these Black community midwives and their clients. We had 3 distinct data sources. So we had interview data. We had these 5 case midwives and the 50 key informants. And so for every midwife, we had about anywhere from 10 to 13 key informants around that midwife. Another data source was midwife-client observation. So looking at the interaction between the clients. So I was invited to just observe the midwife with their clients. And we also conducted client surveys, about 16 client surveys, looking at autonomy and decision-making as well as respect. In total, for every midwife, we had about 10 hours of observation data, except for 1 midwife. We were able to observe 4 of the midwives. 1 midwife, we were not able to observe her because she moved in the course of doing the research. But for the other midwives, so we had about 45 hours of observation. And I think for the interviews, we have about 100 or more hours of interview data as well. All right, so let me give you a sense of the people in the study, and these are people we interviewed, primarily female. Of course, we're looking at maternal health. 50 of them were identified as female. Most of them were married. About 72% were married. Most of them were Black, identified as Black. In terms of their sexual orientation, they primarily identified as straight. There was some LGBTQ+. In terms of spirituality, a large proportion, almost 80%, identified themselves as religious and or spiritual. And the age range from 26 to 84. All right. So in terms of services, I were able to identify from the interview essential 11 services that the midwives provided. education, not just of the pregnant person, but of their families, social emotional support, counseling around diet and nutrition. Client advocacy was also a service, really helping these clients, go into the hospital or go talk to their OBs or just navigate the health system. Access to social networks, whether it be around parent, homeschooling education, whether it be about referrals to community resources like pediatricians. Childbirth exercise was another medical, of course, there are medical tests that they provide, urine tests and blood draws and glucose tolerance tests, etc. Physical activity counseling, community education, spiritual support, and physical exams. So these were the services. In terms of the three most mentioned services and the services that people spoke most passionately about was in educating and integrating the family unit, the social and emotional support, and nutrition counseling. So here we use a pseudonym for this client. We've named her Samantha. Here's how she's talking about the family, the integration, the education and integration of the family. She says, the midwife didn't just address me in my care and what I needed to do and exclude my spouse. She included him 100%. She told him ways that he could affirm me every day, ways he could make sure I was following my diet, just giving us helpful advice on workouts and ways that I can involve my daughter, who was 7 at that time. And it was just priceless because we had never experienced that before. Give me a minute, please. And people were juxtapositioning that with the prior experience they had in conventional care. We also identified what we call the values that guided the midwives. And there were 4 primary values. One was they should be patient. One was client autonomy, client or patient autonomy. The other was client safety. Spirituality was another value. And the last value was we called deep care. I'm just going to let somebody into the room. There's still people showing up. And so I want to talk about deep care. This is a really important value. And that is the value that we're going to be focused on, because it seemed of all the other values, it had a really unique place. People talked about it the most, right? And they talked about that's what they appreciated, and and that's what they used to compare the care they got from their midwives with what they got, for example, from their OB. And deep care and we named it deep care. When I was observing them, I saw something that I had never seen before. Friends, I was not trained to provide care like that. I had not experienced care like that. And when I was a provider, I did not give that kind of care. And what I would say deep care is love-centered care. As I say, kind of tongue in cheek, I had never seen care, love, laughter, joy in the same company with a blood test and a urine analysis and belly checks. Okay, good. So when people talked about deep care, we saw there were like 4 what I'm calling overarching themes or archetypes of the midwife that people referenced. One was the midwife as a conscious, love-centered clinical practitioner. The second was a midwife as educators, advocates, and system navigators, right? So clients would go to their OB and spend 15 minutes or 20 minutes or however time, and they would come back with questions, and they would take the questions to their midwives, and the midwives would help them figure it out. And sometimes people saw both their midwife and their OB. Sometimes they saw it because there was a need to, because they needed a higher, in addition to midwifery care, they needed a higher level of care for some complexities that they had in their pregnancy. But sometimes they saw OB just because midwifery care is not covered by insurance. And so they needed, the OB services and the conventional medical services to take care of, the blood test and the ultrasound and all those things so that they would not have to pay for it out of pocket. The third theme was midwives as cultural and family integration practitioners. And we'll talk a little bit more about that. The fourth was midwives as spiritual, ancestral, and emotional practitioners as well. So these are the four distinct archetypes that came across in the research. So let's take the first one, midwife as conscious, love-centered clinical practitioner. Here is Maria saying, I'm a first-time mom. I had a million questions. And we heard Maria on the audio. She says, okay, you want to have the last appointment. That way I can have a longer time to talk to you. It meant so much to me. It made me more comfortable, made me more trustworthy towards her. I felt loved. I know you don't feel that a lot about your providers, but literally, I felt loved by her. And I want to say something like, so here I am, I'm doing this research, and we're interviewing people and I'm observing them. And I'm not the only person doing the research. There's a study team also doing this research, right? Helping me do this research. And I'm observing these midwives, and I would come back to my study team kind of sheepish. And I would say things like, I think the midwives love the clients, but I'm like, am I projecting? Can this be? Because I had never seen anything like this. And so I'm so grateful that we have, the power of triangulation. So here I am observing these midwives with their clients, just observing them. And we have other people interviewing the clients. And I'm thinking wow, that looks like love. And then the clients are saying, I felt loved by this. Okay, so now we can turn our attention to theme 2. These midwives as educators, advocates, and system navigators. Mia, who is a collaborating provider, noted about midwifery care. And so she's talking about the way these Black midwives, the Black midwife who is a collaborator is caring for the Black client. And she's talking about this case. She says, and it was a little hard, right? So she's talking about a mother who was having challenges. She said, and it was a little hard because the mama had food aversions and wasn't really nourishing herself enough. But midwife convinced her to really commit to herself more, even when this mama didn't want to. This mama had so much fatigue, and midwife lovingly, maybe it's a Black woman to Black woman thing, got her to do it. She got her to walk. She got her to take all of her vitamins, start drinking smoothies, just to better care of herself. So this is, again, midwife as educator and advocate. The third is midwife as cultural and family integration. So the midwife's husband is here talking about the family and how important the family and also the community is around birth. And that's something that I did not understand. I came out of this research completely transformed in terms of my understanding of what birth is and what it can be. So Nathan, who is the midwife's husband, says, but the midwife approaches her care from a communal understanding of birth. This is a family experience. This is not just an individual experience. It takes more than one person to create this life. It'll take more than one person to raise and foster this life. You're all in this together. Everybody has different roles. And so one of her roles, talking about the midwife as a provider of midwifery care, is just that, to make sure y'all are in this together. Right? And so this is really, I thought was really powerful. And the last archetype is midwife as spiritual, ancestral, and emotional practitioner. So Maya, the midwife, describing the role of spirituality in her care. And she is saying, you're tuning into things, right? These are things that you cannot see. And you're helping that mother tune into those things. What do you feel? What do you smell? And then on top of that, it's how this person is connecting in a spiritual way. And it can be anything. It could be your God, it could be your ancestors. How is that individual connecting to their spiritual side? Because we're deeper beings. It means there's so much that makes us who we are. I think that's what I would say about traditional midwifery. So we came out of this research with three big recommendations. One is to shift the public attitudes about midwifery. The second is to increase affordability and availability of midwives. And the third was to improve hospital transfers. And here you have some quotes about insurance and about how we need to be broadcasting what is possible around midwifery. All right, so let's talk about the dissemination, translating the Black Birthing Futures findings into accessible public and social media content. So our first way we do that is through Instagram Reels, right? We're sharing our research findings on social media. We want to reach a wider audience. Our team developed the Black Birthing Futures Instagram page. We're disseminating our research findings there. We're uplifting community resources and amplifying the work of our local partners. I think it's a really important role that we as researchers play is to amplify what's already happening. We share educational reels addressing frequently asked questions, and we highlight the midwives we collaborate with, centering their expertise and their experience. And we do more things here. So friends, I know I'm on social media. Our other is the Deep Care podcast. The Deep Care podcast, our title is Deep Care, the Black Community Midwives, Transforming Black Families and Futures. It's a narrative nonfiction podcast about Black families seeking better births and the community midwives that are helping them to move forward. I narrate it. We follow 3 midwives and their clients in the South, Midwest, and West. And what we do is to showcase the unique contributions of midwives and what community birthing offers to Black birthing people and to people generally. So in terms of the elements of the podcast, we employ solution storytelling. It is, of course, we've published papers. I told you about a paper coming out in midwifery. We have our papers under review, but this is our big push because we want to interrupt the despairing discourse around Black birthing by uplifting grassroots solutions. So it's very intimate storytelling, like you heard. Every episode centers about the stories of community midwives and their clients. And we really the field we're going after is like being in the room. So that's me. The picture we have on the left is one of the midwives, and you can see, I'm off to the side and the client is sitting on her couch. She's kneeling down and she is doing a Doppler, a fetal Doppler, and the client has her phone and is hearing the sound and observing the baby. And this is based our research. We did the analysis first. So in 2024, we spent all of 2024 doing the analysis. And so we're building this podcast on top of the findings of the analysis. So story breakdown, we have 6 episodes. The first episode, and these are the titles, is The Calling, A Midwife's Journey. I introduced the midwife, a Black Kim H., a Black community midwife in Florida, who is giving, helping a Black mom who have a safe, healthy, and joyful birth after 2 traumatic births in Florida. Along doing that, I also unpack the Black maternal health crisis, and I reflect also on my experience as a medical doctor. The second episode is titled Guide, Friend, Auntie. And it says pregnancy care begins at home. And then we go inside a prenatal home visit. And here we explore the unique ways that midwives care for their clients. The third is titled The Care Never Stops, How Midwives Build Communities of Support for Their Clients. And we're in LA. So the first two episodes were in Florida. By the third episode, we're in LA and in an LA birth center. And we're looking at all the network of support that the midwife builds for their clients. And in episode 3, we meet Joya, who finds herself at the center of a circle of providers and friends who support her during her pregnancy. The fourth episode is titled Birth Rebirth, How Midwives Support Family Through Pregnancy and Loss. We're back in Florida and in Missouri. So we look at two pregnancy outcomes. One is a live birth in Missouri, but the other is pregnancy loss. The fifth episode is Postpartum is Forever, the fourth trimester. And here we dive into life after birth and how the midwives hold not just the pregnant person, like the birthing person, but the entire family during the postpartum period. And if we think it's really important, because it's a time when a lot of the support falls by the wayside. And I just want to say these midwives have known that the postpartum period is at least a year, and the 6 weeks that we typically think of as postpartum is quite arbitrary. The sixth episode is titled The People Could Fly, The Dreams That Black Communities Have for Birth. And here we invite our listeners to dream. After witnessing the potential of community midwifery, I imagine a future, the year is 2050, and the Black maternal health crisis is over, and Black birthing is safe and joyful. And then I ask, how do we get there? Our audience, we're primarily aimed at Black birthing people of reproductive age and the people who love them. Like, remember the recommendation came out of this research is that Black people need to know their birthing options. Like, that was the mantra. Like, people kept on telling me that over and over again. And so this is my calling to advance that. So we're trying to show the viability of community home birth for Black birthing people as an alternative, as one among the choices that people have. And we really want to dispel the myths around midwifery as unsafe and midwives as uneducated. And that's a legacy we have from the Jim Crow era. And that's a legacy we have from the late 1800s when the American Medical Association and physicians really attacked midwifery. Their concern was they didn't want midwives to compete with them. They didn't say that, but that was the bottom line. Our secondary audiences are doctors, policymakers, and the general public. In terms of impact, we want to elucidate the viability of the community births. We want to dispel the prevailing myths, and we want to reduce birth trauma and improve birth outcomes long term. In the short term, however, we want to increase awareness and visibility of this work. We certainly want community engagement around reproductive health and community birthing, and we also want energized grassroots policy advocacy. And we're supporting the beloved Birth 50 by 50 goal to make, by 2050, 50% of the births in the US will be supported by midwives, whether at home, in birth centers, or in the hospital. Next steps, I'm wrapping up. So on Friday and Saturday, we're going to be having what is called the Beloved Birth 50 by 50 convening, where we're partnering with Birth Equity, Birth Center Equity, where we are partnering with the National Association of Certified Professional Midwives. We're also partnering with Black Midwifery, Black Midwives Collective, to have a narrative change meeting because we want to set up the goals to shift cultural norms around midwifery-led birth. Our podcast, the first episode, the trailer is available, but our first podcast will be released next Monday, and we're really excited about that. I'm inviting everybody here to listen to the series. You will not be disappointed. And a new episode will be released every other Monday. I'm going on a multimedia tour a media tour of the South, radio and television next week. I'll be in the South, radio, TV, local TV, as well as national TV, really highlighting midwifery care. In terms of the next steps, me and my team, we would wanna, yes, it's one thing to have a podcast and to make people aware, but a social impact campaign is really important. Really getting people from awareness to action, right? Getting stakeholders engaged, energized, and in action. We'd also, the research we did brought up some areas for us that we'd like to explore. One of which is really strengthening pregnancy self-care, really bringing more power and autonomy to the self-care space. And so really looking at that. So doing research, doing social media research in that space. Another area we would like to explore is a multi-sector collaborative, really drawing on strengths, on what we know is working to address the Black maternal health crisis. Our team, we're wrapping it up. So here is our team. We have Kamara Aaron as our lead producer, Gabrielle Horton as the story editor for the podcast, Sally Bouvet as our audio producer, Brie Evans, associate producer, Lucetta McGroy, who's at Hopkins and is in the Department of Health Policy and Management with me, but also at Kennedy Krieger, has been a co-investigator. Jim Awuli is our administrative and research assistant. Kimberly Pothmont is our research assistant, and Maria Jose Owens Farhado is our creative and strategy producer. Thank you. You can follow us on Instagram. This is our email. It says Black Birthing Futures. It's Black Birthing Futures at, not at Gmail, is at jhu.com. That's a mistake. And this is a QR code. If you please take out your phones and scan the QR code, and it'll take you to our website where you can listen to our trailer. And you can also access Spotify or Apple or NPR, right? You can listen on our website, but you can subscribe to our podcast from our website. That's it, friends. So I'm going to stop sharing so we can be in conversation.
Thank you. Bravo. That was excellent and so interesting, inspiring, and definitely a different view of health equity research. Like not only the qualitative research piece of it, which is also, I think, very fascinating, but the actual use of storytelling and the use of communication, health communication strategies for dissemination and for advocacy. So, so exciting for such an important, issue. And also, I just love the asset-based approach, strengths-based, really focus on strengths and culture and, ancestry and all those wonderful things that we know give life and give health to people. So.
Absolutely. Lisa, I'm happy that you like it. And I want to say that if you guys want to do this kind of research, I would love to partner with you. Me and my team, we made a huge investment in this, as you can imagine. And we have relationships now. We have know-how that can be leveraged in the wider Hopkins community. So that as a methodology for that, I'm down, and our team is down. Absolutely.
Oh, thank you for saying that. We will have follow-up conversations about that. So on that note, Dr. Cruz has a question, so I'll let her go first because you were, talking about how much you invested in this. So maybe after you answer Dr. Cruz.
Oh yeah, yeah. And I saw the comment in the chat. So wonderful talk. Thank you so much for sharing with us. I was curious, given the the term I learned today from you, deep care, right? And that it's so love-centered. I was wondering about two things. One, what have you learned through your work that makes for an effective midwife, right? Given that that it really is what the job is, and that's what people seem to be responding so much to, is the deep care. And then related to that, have you found in your work like that midwives need support in this work? Because I would imagine that they really bear, because it's love-centered, right? And people are perceiving that they love them, and they probably are, and they probably do love the people that they're working with. What have you found has been the impact
Yeah.
on midwives?
Yeah, thank you so very much. Both questions are really helpful questions. I think of course, no, so I just want to say these are midwives that raise their hand and say, yeah, come observe me, right? So, we're looking at that. And I think what I was really encouraged by is what is possible, right? So the takeaway is not that every midwife does that. The takeaway is that this is what is possible. And this is what almost nobody in the United States experiences. And definitely probably no Black person experiences that kind of care. So that is point number one, right? Because I was really wanting to be cognizant of that. That's the first point. The second point, I think the effectiveness, and I'm just so happy you asked me about this question, Dr. Cruz, is that I think there are two things. So yes, there is technical skill, and these midwives have a lot of technical skill, right? They have a lot of knowledge in many, many different areas. They know nutrition and movement. They also excellent clinicians, right? Knowing the biomedicine. So they understand that, right? So they're good technically, but they also are good in the interpersonal and love. They're also good in the caring space. And we wanted to say deep care because we talk about healthcare. But as some of we have an anthropologist who is guiding our study says, what in medicine we call care is not care, is service, because there's very little care. And care includes a couple of things. There are different dimensions to care. One of care is listening. There are different phases of care. One is attunement, listening, attentiveness. The second dimension of care is taking responsibility for the person in front of you, meaning that you are responding to it, not that you have to do everything. And we saw that so much. I saw that so much in my observation. And third aspect of it is actually the caretaking, right? So the technical piece. So I think an effective midwife or an effective clinician, I think I'm going to expand that to people taking care of us. They have to be technically competent, but they also have to care for us. And I would also say, I don't know how it will land with this audience because we have all of us, grew up on biomedicine. But I also want to say, and I'll be saying that, if your doctor or the person you're working with doesn't care for you, I think you should keep it moving. Find another person. If that person doesn't love you, keep it moving. Because I've come to understand how important care is, and it changed me. So I had a pulmonologist, and I fired her, and I don't think I would have fired her without this research. I'd be like grumbling. I'm like whatever, rolling on. But it is that important, care and somebody to care for you, because if they don't care for you, they cannot listen to you. If they don't care for you, there'll be other priorities. They'll have to shop. They'll have to do something else. They'll be easily distracted. They'll need their golf game on a Friday afternoon instead of taking care of you. They'll need, they're all the things that people tell us, that's real. That is real. And I think when we have a care framework, we begin to see these people are not being petty, or we know that. But science and research and social research supports that, and psychological research supports that. So that's that for that. The effectiveness, what it means to be effective. The other thing is that we need love to heal. I'm going to say it again. And nurses have known that. We need love to heal outside of, because love is speaking to us at the level of our central nervous system. That's what's happening. And for Black people under stress, the midwife said it's like running a marathon and fighting a war. This is a high inflammatory state. I don't know if you guys read the book Inflamed. Where's my copy? I mean, it's an amazing book that I think all of us should read. It's this book, Inflamed, and it's by Rupa Maria and Raj Patel. And it talks about inflammation and the role and how all, diseases, the common pathway is inflammation, either through the stress or through the immune system, right? I mean, so I think we have to really, I think we have to really understand that. In terms of the kind of support, they're doing a lot. It's hard. There's burnout, and that's real. And in episode 6, we really talk about the things that need to happen, for midwives to stay in the field. So what we have is these individuals, right, drawing from their own resources to do what is a social good. Right? As a society, we shouldn't put what should be institutional responsibilities on individuals. These women are standing in the gap, and I think it is honorable and it is heroic. It is not a national strategy. So I just want to say that. I don't know if that answers your question, Deidre, but I think I've said a lot. So I think it's time to pause.
That was fabulous. I don't know, Deidre, did you have anything else to say?
Thank you. You responded fully. Thank you.
So I'm going to read a question from Dr. Chidama Ibe in the chat, which is about the funding, how you are funding your work. I imagine you're tapping into multiple sources to support the range of activities you're doing.
Yeah. So the research was funded by the Robert Wood Johnson Foundation. And right, so that's what the research was about. But for the podcast, we funded it I self-funded it. That's one. 2 is we got grants from the Wagner Foundation and the Commonwealth Foundation. We got small grants. I always say, I believe in you money is the best kind of money. And the Wagner Foundation gave us a small grant, and just a lot of encouragement. They were the first, when they heard about this, they're like, yes, we want you to have this like $45,000 grant. And so, I mean, podcasting, it looks like, I'll just be transparent with you. Like a podcast like this is probably about $120,000. My time was supported more than that, maybe 150. My time was supported by the parent grant. And then we have these other grants. I said it was self-funded, so I also took money from my savings to put into it. And the Commonwealth Fund, so Wagner came in first to get the story editor, right? And there's a lot of work that goes into that. They have to listen to the audio and say, okay, the analysis, we share the analysis with them, like, okay, what is the story we want to build around that? And then the Commonwealth Fund recently gave us a grant, and we're doing marketing, and we have PR to help us, break through the noise, and social media. And so that's what we, that's how we've been able to fund this. And I'm up to having a campaign as well. We didn't have to, but I was ready, Lisa, to send you an email, give me $50 and this person, we may still do that, but like a fund, like a crowdfunding campaign as well. If we need to do that, we're going to do it.
That's awesome. Thank you. Very inspiring.
Sorry for interrupting, Dr. Cooper. I just wanted to say thank you so much, Dr. Felix. That was a great It was just very inspiring. I can't believe you pulled from your savings, but it really speaks to really the fact that this has long been an emergency issue. And so just thank you so much for inspiring us.
Absolutely. Go listen to the podcast. You will fall in love with these people. Like they are like amazing protagonists, right? Like you will fall in love with them. And one of the things that surprised me is that like I knew like these midwives were gonna be like, yeah, man, really amazing people. The clients, I said, these clients had to slay dragons to have their home birth. They had not, I mean, not only the money was a challenge for them, but the family resistance. So part of why wanted to do this, Dr. Ibe was, one, they told me to do it. I mean, we asked them, so of course they agreed to do the research, and that was great. We also asked them to give us media release, and 70%, almost all the people we started to ask for media release in, maybe a quarter way in the research. And almost everybody we asked to sign saying, hey, can we use your audio in this podcast? Can we use your name? Almost everybody agreed we could use that, right? So that's the kind of generosity we saw, and people saying, we can do better. We can do better. You need to get this story out. And so I just couldn't wait for some grand person to say, yeah, I mean, we just had to get going and trust. You guys know I've spent most of my career in funding organizations, and I've always felt like good money follows good ideas. Sometimes you just have to get started. And I said I was a spiritual activist, so let me give you a little bit of spiritual thing. One of the things I learned is that the Holy Spirit cannot do its work if we're not in action. So we need to be in action for the Holy Spirit to do its piece.
Wow. Well, thank you so, so much, Kaytura. I was thinking of like, we often talk about like the three major buckets of solutions to health disparities or ways to advance health equity, and one of them being, and so much of what you're doing actually falls into like all three buckets. But the first big bucket is creating opportunity within communities, like addressing social determinants of health and making sure people have healthy places to live and work and go to school and play and worship and all those things. The second big bucket being like healthcare, making healthcare accessible and equitable, and making sure that we deliver high quality care and that we include all the people that we need to be included in that. And then the third one is this whole business about building public support and building community strength. And I think this kind of work, it really exemplifies that, because it really gives the power back to people. People already have that power, but it's actually making sure they can use it, and that we actually communicate that message to other people.
Yeah. Mm-hmm.
So anyway, I love this, and I'm sure everybody else has been really inspired and excited by your work, and we look forward to hearing more and talking more with you about potential collaborations. And
Happy to. After the podcast launches now,
okay,
because I'm deep
not
into
tomorrow.
podcast launching and this media thing that I'm doing next week. That looks a little crazy, but I'm like, yeah, let's do it.
Sending you positive energy for
Thank
all
you.
of
Hold
that.
me on Monday. If anybody has some time on Monday, be sending me positive energy prayers, because I'm going to be probably doing like 6 interviews, TV and stuff on Monday. I've never done that before, but hey.
You will be well, because this is a very important and inspiring message. So I'm sure all will be well and well received. So I want to thank everybody else for joining us today too. And yeah, we look forward to seeing you all next month, and have a good rest of your day and week.
Thank you, guys.
Thank you,
Thank
Dr.
you so
Felix.
much. This was
Okay.
so good. Fed my soul.
Well,
Bye.
fed our souls too. Okay.